Hello, I'm Dr. John Kruse, and today I'm going to be talking about, is tolerance to stimulants a problem? So I will start with the take-home message for a minute or two, summarizing the message, and then launch into the main body of the talk. So the take-home message is that stimulants are consistently found to be the most effective medication for ADHD. And most ADHD experts state that after some initial sorting out of getting the dosage right, that most people with ADHD continue to do well and stably on the same dose of stimulant medication for years and years, often for decades or more. On the other hand, the addiction experts assert exactly the opposite. And almost everything they write about says everyone develops tolerance to stimulants, and most people it happens pretty quickly. And if that were the case, then you would expect that everyone would need to keep escalating their dose to maintain benefit from the medication. Now, the dopamine system, from everything we know so far, appears to have a central role in creation or the causation of ADHD symptoms, and at least there's a strong association between dopamine systems and ADHD symptoms, and responses to ADHD medications pretty clearly are connected to the dopamine system. And the stimulants clearly and many non-stimulants are acting on the dopamine system. And specifically in the dopamine system, both methylphenidate and Ritalin and amphetamine products and a number of non-stimulants are binding to the dopamine transporter molecule, and which blocks the reuptake of dopamine. And most of the emphasis or focus so far on tolerance to stimulants is focused on that dopamine transporter, and specifically one study from 2013, which still gets a lot of attention. So that's the take-home message. Jumping into the main talk itself. Exposure to a medication or any substance over time, a couple different responses over time can happen. One, you can keep getting the same response. You could keep taking your vitamins every day and getting the same response. You could keep eating your bacon and eggs for breakfast every morning and get the same response. You could keep taking your diabetes medication every day and get the same response. There's also a process called sensitization, where you get more strong response over time to the same stimuli. Some of the most dramatic examples are with our immune system and allergic responses. So the first time a kid who's allergic might be exposed to peanuts, he gets a rash around his face, and then the next time he may have shortness of breath, trouble breathing, and then third time a full-blown anaphylactic shock. So sensitization is one direction, but the opposite direction is tolerance. So tolerance means exposure to the same substance leaves you with less of a response over time. And again, that can lead to requiring or taking a higher dose to get the same effect. An important point to map out here is that tolerance is a component of addiction, but you can certainly be tolerant to something and not being addicted. So addiction is defined different ways by different people, but not only requires tolerance, but requires craving the substance, requires indulging in the substance when it's clearly having detrimental effects on your life. And there's a related phenomenon to tolerance called tachyphylaxis, which is a fun word to say and spell. So tachyphylaxis is sort of viewed as a quick tolerance, but it's happening by different mechanisms. And usually tachyphylaxis is associated with something like depletion of a store of neurotransmitters, so that you might send a signal in and get a robust response the first time, but the second or third time, as you get more depleted, it's not able to respond as strongly. So it looks like you need a bigger signal to get the same response. But if you give the system a break and it can restore that neurotransmitter store supply, then it's going to give you an equally strong response to the same stimuli. Again, if you give it time to recover. So tachyphylaxis is somewhat different than tolerance, where it's a chronic process. With tolerance, where unless you give it months and months or a long, long time to recover, you're not going to recover the same response to the same stimulus. So in the dopamine systems in our brain, the dopamine levels are the most important variable controlling dopamine levels in the brain are the dopamine transporter, or the dopamine reuptaker molecule, sometimes referred to as DAT or DAT. So when dopamine is released by a presynaptic synaptic ending, dopamine floats across the space, the synaptic space, binds to receptors on the postsynaptic neuron, and if nothing else happened, that some signal would just keep going and going and going. We need a way to shut it off. The way it's shut it off is that the molecules are diffusing on and off the receptor, and they diffuse back to the presynaptic nerve, where the DAT molecule, the dopamine transporter, sucks them up. That's the most important variable, the action of that dopamine transporter for ending the signal, for pulling back dopamine, ending it. There's also enzymes that break down dopamine, monoamine oxidase, MAO, and catecholamine O-methyltransferase are both important for breaking it down. But in terms of day-to-day functioning and flow and effect, those are smaller effects than the dopamine transporter. So in ADHD research, and there's a lot of variability, but in general, a overall summary is that dopamine symptomatology seems to be associated with having chronically lower levels of dopamine available, and there is higher levels than normal of dopamine transporter molecule available, and particularly that's found in the striatum, the caudate and putamen deep in the brain. But again, there's lots of variability. And we know that dopamine transporter molecule is affected by a lot of things. So there's circadian rhythms to it. There's seasonal patterns to how much is available and working. There's gender differences. Among females, there are fluctuations across the menstrual cycle. And one other thing to remember is that often we're looking at just the number or density of dopamine transporter molecules, but it's not just the number that's available, but how functional there are. So there may be some chemical interactions that can change how function, inactivate them or activate them, where it looks like they're there, but they're just not performing as well or as strongly. So again, there's a fair amount of research that suggests that dopamine or ADHD symptom severity is associated with states of low dopamine available and high levels of dopamine transporter activity or high density. So the study that gets so much concern and attention still is a 2013 study conducted by Nora Volkow and her colleagues, and she's been the head of the NIDA, National Institute for Drug Abuse, for many decades, a very prolific and highly respected researcher. Just interestingly, we mention as a side that NIDA is actually part of the National Institute of Health, not part of the National Institutes of Mental Health. Why we break it up that way has to do with politics. Anyway, her study, and she had multiple collaborators, looked at 18 adults with ADHD. These were adults that had never been medicated before, never treated before, and compared them to 11 control subjects who did not have ADHD. They matched them on the basis of age. So the average age was about 31, 32. They were matched for socioeconomic status. They were matched for education. All 29 subjects had a PET scan done at the baseline. The PET scan was measuring dopamine transporter density in the brain, particularly the caudate and putamen deep in the brain. And then 1 year later, and they had a repeat PET scan to look at what had happened with dopamine transporter density. And in the interim, during that 1 year, everyone in the group of 18 ADHD subjects was treated with methylphenidate. That dose was titrated up to an effective level, so it wasn't a fixed dose. It was what worked for each individual in terms of targeting ADD symptoms. Average dose was mentioned to be about 1 milligram per kilogram per day, which is about 70 kilograms if this was an average weighted American population, 70 to 80 probably. And the ADHD subjects had a clear, robust response of their ADHD symptoms to this methylphenidate treatment, and it was across the board. Inattentive, hyperactive, impulsive symptoms all responded. And at the end of the year, the control group didn't show any difference from baseline to a year later in their density of dopamine transporters. Excuse me. But the ADHD group, who had been on Ritalin methylphenidate for a year, showed a 24% increase in dopamine transporter molecule density in the caudate and in the putamen. That was a substantial, statistically significant increase, and the paper cited that this upregulation may decrease treatment efficacy over time and exacerbate symptoms while not under the effects of medication. So the claim was, or the possibility is, that if you've been blocking the dopamine transporter, I guess I didn't make that clear earlier. So if dopamine transporters are blocked by methylphenidate, blocked by amphetamine, blocked by other stimulants, if you're blocking it, then the system may try to compensate by making more of those dopamine transporters, which means then you'd need a bigger dopamine hit or bigger drug hit to counteract that and to continue to have effects. Now, so that seems alarming, this is, but there's some problems with the study. So one thing I should point out, there have been other studies showing what are the effects of giving, particularly Ritalin's been more studied, but also amphetamine to people with ADHD, what happens to dopamine transporter availability. Some studies, particularly acutely, some show decreases in dopamine transporter, some show increases, some show no changes. So there's been a discrepancy in other studies compared to this one. There's certainly others that support an increase in dopamine transporters with chronic or longer term, and it seems the longer the duration of treatment, the more likelihood of increased dopamine transmitters found. One important thing is that the study highlights, and one of their conclusions was some of the discrepancy among studies may have to do with how long people were treated before entry into their specific studies. But there's a few major problems. With this study, or focusing on it, is showing that everyone's going to have tolerance because they've produced more dopamine transporters. One thing, it was a pretty strange, population of individuals with ADHD just on a gender basis. So of the 18, 6 of the 18 were male, which means only 33%. Most ADHD studies are male biased. This was under-biased. But in the control group, they did not match for gender. So 82%, so 9 out of the 11 controls were males. So right there, that's adding weirdness to the study. There was no mention in terms of the protocol whether they were careful to do the assays at the same time of day, because again, there's circadian rhythms in dopamine transmitters, or with the women. This they specifically mentioned they did not control for the phase of the menstrual cycle, or even, if they're doing the before and after at the same season, then the before and after for each patient should be done in the same season, but different patients or patient control groups might have skewed differently for different seasons. So the other, big finding or weakness, and they point this out because it would be hard ethically to do it, is that this looked at a group of individuals with ADHD who were on medication and what happened to their dopamine transporters over the course of a year, but they didn't have a group with ADHD who were untreated across a year to compare to, and they didn't have a group of control subjects who didn't have ADHD who were given Ritalin for a year to see what happened to their transporters. So, there's lots of weaknesses to this study, and makes it hard to generalize it or know how valid or useful it is. The other thing to be said is that there are a number of other studies. Many of them have used shorter treatment periods. More of them have been more heterogeneous in terms of the patient's prior exposure to medications. But several studies have shown that the changes in dopamine transporter density, so several studies have found either upregulation or downregulation or differences at the end of a period of exposure, have showed that usually within several days after stopping chronic treatment, density of dopamine transporters tends to renormalize or be close to where it was at baseline. So even if we're having some effect, it seems, at least in some animal models, some human studies, dopamine transporter itself seems to be able to readjust or snap back into where it had been. There has been at least one study, though, in rats showing that after long-term methylphenidate exposure, that the long-term changes, so outside of dopamine transporter right in the striatum, but secondary effects, presumably in the prefrontal cortex or synaptic connectivity within the striatum itself, seems to be changed for a longer period, even after an extensive washout, even after the drug has been stopped for a while. So the bottom line is we still need a lot of work to do to see what neurochemical markers are changed by chronic dopamine treatment. And I would point out that even if things are changed, that doesn't mean it's bad or that we're fostering necessary tolerance or dependence. Changes could actually reflect the opposite, that we are normalizing the brain or making it less like a typical ADHD brain and more like a typical non-ADHD brain, and maybe actually decreasing the need down the line for greater treatment. Again, the tolerance question, if we're creating tolerance, that suggests the person is always going to need the drug to be obtaining a benefit for their ADHD symptoms. Again, we just simply don't have we don't have enough data to know what in general is happening. So one of the counters to this is I just looked at my clinical practice. This is a little study I did 3-4 years ago. It's during COVID. So I looked at, and I just alphabetically started in my patient list of patients who were on stimulants, who actually had been on stimulants for a full year for ADHD. I have a very small number of people who take stimulants for depression because their regular antidepressants weren't working well. So these were all adults, 100 people on ADHD or on stimulants for their ADHD for at least 1 year at a stable dose before studying. And then I just looked at 1 year later, where was their dose of stimulant? Was it up? Was it down? Was it the same? And 80% of those were on the same dose. Of that 20% who changed their dose, actually only 7% went up, 13% went down. If you think that's a little weird, that may be atypical. So this was done during the midst of COVID, and a number of my patients experienced a significant amount of anxiety due to disruptions during COVID. And anxiety is often a compelling reason to decrease a stimulant dose so that you're not exacerbating the anxiety. So I'm not pretending my patient population is representative of all individuals with ADHD. I think the very fact that some people did change their dose shows that I do know colleagues who, and I've heard reports from many incoming patients of doctors who will absolutely never change or allow an increased dose for ADHD stimulant medications. My talk on high dose medications was just a week or two ago. There's another video on that. So the fact that some people change showed, I think, that patients are willing to bring up the topic and feel comfortable and that I'm willing and adaptable to change. So it's not that I think everyone needs to be, and that's why my data was locked into the same dose, because I insisted everyone stay on the same dose. And maybe in our non-COVID year, there would be even greater continuity, greater than that 80% on the same dose. I don't know. The other sort of related question buried in there is that, and this was mentioned in Volkow's article, that possibly patients who miss a day or two of their stimulant are going to feel worse when they're off their medication because of this upregulation in dopamine transmitter systems, dopamine transporter. And I can certainly say a number. I don't know what that number is, but it's not a trivial minority. I'd say many people on stimulants in my practice or experience have commented, gosh, the days off of it, I feel I'm really dragging. I'm doing much worse than I remember doing. Mostly it's fatigue they're talking about. Sometimes it is specifically ADHD symptoms. So the bottom line is despite one study and a handful of studies suggesting changes, upregulation of dopamine transporter systems from long-term exposure to stimulants, we don't have a good handle on how pervasive that is, how often that persists if you should stop, how often that's problematic in terms of promoting tolerance or dependence, or how often it's actually helpful in some ways, normalizing the system and allowing it to function better in the long term. So that's all for today. Thanks for being here, and stay healthy and happy.